What do you think? Good to go?
Yes, I'm going to go ahead and I will go ahead and introduce you if that's okay.
Of course.
Excellent. So we're very fortunate to have Dr. Amy Compton-Phillips with us today. Dr. Amy Compton-Phillips is an internationally respected healthcare executive, innovator, speaker, and author, serving as Executive Vice President and Chief Clinical Officer at Providence. She is also oversees 51 hospitals, 800 plus clinics, 115,000 caregivers of the $25 billion health system. She serves on boards of the the Institution of Systems Biology, Lumedic, Multi-Scale Health Networks, and chairs the High Value Healthcare Collaborative. Prior to joining Providence in 2015, Dr. Compton-Phillips served 22 years at Kaiser Permanente. She's got her bachelor's from the famous Johns Hopkins University and her medical degree from the University of Maryland School of Medicine. She is a board-certified internist with strong interests in innovation and wellness. And I will tell you, Dr. Compton-Phillips, Amy, I will tell you, of course, I saw you initially, of course, on CNN. She is a regular now on CNN as a healthcare and medical analyst. And when I was so fortunate to reach out to you, and you were so kind and so open to agreeing to speak to us today, you know, I obviously had put the word out about this event, and my good friend who's on here, Dr. Barry, he's an incredibly well-respected faculty member at Mays Business School, but his speciality is in healthcare and services marketing. And when he said, "Oh, I'm so glad you've got her on," because he was well aware of you and everything. And that was for me, that was all the sort of, the message saying to me that I definitely got the right person on. So yeah, it's really fantastic having you. And thanks a lot for taking time with us today.
I am absolutely delighted to be here. And I have to tell you, my secret little favorite thing to do is to help grow the next generation. First of all, because it reminds me of my days back when I got to be a student, which is take advantage of this now, guys, because eventually you're not anymore. You have to actually enter the real world. But the second thing is you guys keep me fresh. If you ask me hard questions, I have to think more, and I have to think about hard questions. And so I find that I'm much more on my toes if I interact with people that are in active learning mode. So thank you for the chance to be here today. And just to call out, because I asked CNN, it's like, why do you want me on? I'm just a doctor. And they said, because I stopped talking. So apparently that's a skill set that everybody can learn. If you ever want to be on the news at any point, just be willing to say what you say and then stop talking, because I guess it's not as easy for some. So, hey, Kathy Turner, I see you on. Do you have slides that you're able to pull up for us? Thank you so much. I really appreciate that. So Richard talked to me about coming today and talking a little bit about what we're doing with COVID, and just a little bit about where I come from and why I started talking about COVID. If you go to the first slide, Providence is probably the best kept secret in the US. We are a very large health system, as Richard just mentioned. That we have $25 billion in revenue, 51 hospitals spread all the way from Alaska down to Orange County, so all down the West Coast. And then we do go a little bit east. We have a little bit in Montana, a little bit in Texas and Lubbock, Texas. But mostly we're an up and down the West Coast enterprise. And on January 20th of this year, patient didn't arrive till the 21st, but we heard the patient was coming on the 20th. We had the first patient in the country with COVID. And so we've been now dealing with this for 8 months. And so because we had the first patient, for us, all of a sudden, this was real, right? We had been reading about having this unknown respiratory illness in Wuhan, China, but now all of a sudden in Everett, Washington, we had a patient who had this germ. And so we had to all of a sudden go into full on unknown care delivery mode and figure out what to do. So if you go to the next slide, I want to talk you through the phases of how we've been reacting and how we've been working across not only Providence, but also working in collaboration with other large health systems and also with the government and with internationally with other countries to say, let's actually work together to learn faster. And so I'm going to talk you through a little bit about our journey in dealing with the pandemic. And we really kind of think about it as a 3-act play. And so Act 1 was really how we reacted. And we were just kind of constantly going, okay, what's coming next? And we've got to do the next thing, right? And so very quick little things, one after the other. And then we started being able to take a little step back and going, okay, let's think a little bit ahead, and how are we going to respond as an organization, because we know things are going to be happening. We can actually predict a little bit, so we can get ahead of this and not constantly be back on our heels in reactive mode. And then the third phase, where we are right now, is actually how do we recover and renew our healthcare system out of this pandemic? How do we actually use this as a phase shift time for us to say that, oh, healthcare pre-COVID was this and healthcare post-COVID will be that, and end up with a better future because we actually had this disastrous year of 2020. So if you go to the next slide, please. The thing that helped us by getting that first patient before, you know, the country went to hell in a handbasket in that initial phase, is it gave us a little bit of time to plan. So because we knew that the germ had hit the US, go to the next slide, please. We said, we have to actually, it's here. We have to act as if it's going to get here and get big. And so let's just get ready just in case. And so we decided to look across our assets as an organization to say, let's not reconfigure how we're going to do everything. Let's think about what patients need, what the consumer, what the person in the community needs. And so if somebody in the community came down with a cough and shortness of breath, the first thing they're going to do is Google, do I have COVID? Right? So we figured we needed a way to make sure that we could very rapidly and easily, with some highly credible, scientifically valid information, start answering that question when people Google on, do I have COVID? So we called our neighbors across town at Microsoft and said, we need to figure out a chatbot, some kind of natural language learning thing, so that we can, if masses of people start going online, we can help direct them to credible sources. So we developed a chatbot with the CDC, with Microsoft, that then the CDC took and deployed it across the country, which was great. But that was allowing us to actually manage a large number of people at once. And oh, by the way, that chatbot took people through a algorithm that if it did sound like potentially they could have symptoms of COVID, there could be 2 options. One option was to schedule an appointment with our doctor, but another option was to get an Express Care virtual, so an online video visit. And so we were able to directly send people that way. And within the first month, we had something like 100,000 people that did our chat bot, and that went over to about 30,000 people did an Express Care virtual visit, which, by the way, was up from, like, I don't know, I think it was 400 a month before we started this. So it went up exponentially, manyfold, very rapidly. And so we had to figure out how to triage this large bolus of people through a system. And then we had to figure out how to get testing to them. And as you know, testing was a real issue. And so for us, it was kind of this cool thing that we'd heard, oh, in South Korea, they set up drive-through tents. And so we started setting up drive-through tents before the rest of the country did. And how do we get our electronic medical record there? Okay, so we've got to reconfigure things. And so it was like a kind of this cool, constant problem-solving issue. And then for treating patients, we said, let's not do it the traditional way, because we don't know how many people are going to come into our hospitals. If we're worried about people, but they seem stable, let's send them home with a pulse oximeter that can check their oxygen levels and a thermometer, and we can manage them at home where they're much more comfortable and we're not potentially exposing staff to the virus. And so we sent home now several thousand patients that otherwise would have been admitted that we could monitor at home, with a handful, less than 10, that have had to actually come back and be admitted to the hospital. So really kind of thinking through how we can think differently about how to triage, test, and treat allowed us to kind of stay a little ahead. And it was because we were able to plan. We had a little bit of extra time to think through how we were going to manage. Next slide, please. The other thing that we started doing was, okay, this is not just Seattle, right? This is going to hit everywhere. And so we started thinking about how we're going to organize across an entire system and not have everybody have to learn the same thing over and over again. Let's learn it once in one place and share that information. And so we set up this standing daily huddle that we have about 300 people, leaders from every one of our hospitals, every one of our lines of business call into at 7:30 in the morning, where we just go over, okay, what do we have to do? When do we have to do it by? Where do we need equipment? Where are we short on testing? Who has what needs? Who's doing clinical trials on what? How do we get more people enrolled? And really just started doing the logistics management that allowed us to actually navigate through the bolus of people that we were seeing. And then we ended up starting putting things in a playbook and to be able to mobilize our resources so that people could just kind of look down at the, if I do this, then I do that, right? And it allowed us to rapidly scale up from one, we went from 0 to 100 very, very quickly. Next slide, please. By doing that. But it really was through having highly effective communication. We also very early on said, and everybody was talking about it, I'm sure you remember like back, what was it, February, March, and we started talking about flattening the curve, which is probably a phrase that none of you wants to hear again. And we started looking at, okay, how do we think about what's possible scenarios could happen? And we started looking back at the 1918 flu epidemic to say, how did things progress? And we realized that this was going to be a hyperlocal thing. And that we were going to have to be able to, again, 51 hospitals, we were going to have to be able to rapidly redeploy resources from an area that was having a surge to an area that wasn't having a surge. And so we started understanding what are the skill sets of all of our people so that we could, and we developed this entire resource. We have about 50,000 nurses. And we developed a resource that tracked all the skill sets of all of our nurses so that if all of a sudden we had a surge in LA and we needed this very specialized kind of respiratory support called ECMO treatment, and we had nurses in Seattle and Spokane who had that skill set, we could pull them and redeploy them down on a volunteer basis, but everybody was willing very much to work around where they were needed so that we could match skills to people. And we did that specifically because we knew that things were gonna pop up and down, and we knew that early on, and we needed a way to be able to match it. So next slide, please. The other thing we did early on in the reaction phase was okay, we know we're gonna have a wave. Right? We know that we're going to have COVID as a wave. And then in the background, we're going to have these waves going up and down. Don't know how that shape is going to look in Arizona versus Houston versus Lubbock versus, right? But we knew that this was just the reality of what pandemics do. So we planned on that, but we also had to figure out, and at this initial phase, we stopped business as usual. We stopped all the things that bring money into a healthcare system and take money out of a healthcare system and get patients their cancer treatment and get patients their joint replacements and be able to continue to take care of heart disease and all the things that, hospitals are usually pretty busy and doctors' offices are usually pretty busy. All that just came to a screeching halt. So we knew we were going to have to get restarted again because cancer wasn't going away and heart attacks were still happening. And so we had to figure out how we're going to get things going again while we've got this stuff going on in the background. So we started making lots of plans about how to make that happen. Next slide, please. But we also knew, despite the fact that we had this business thing happening, we also knew that we were in the middle of this crisis. And that fact that that COVID thing was going on in the background and that people didn't feel safe and that, we knew that the economic crisis was going to happen. We didn't know the social justice crisis was going to happen, but we knew the economic crisis was happening. So we knew that there was just this morass on its way and that human beings react to disasters in a very predictable pattern. And that the initial response is, what do I do? And then the next response is, I can do this. And they dive in and they're very heroic. And all of our healthcare workers were doing that, right? They're working 24/7 and they're working themselves to the bone and they're putting themselves at risk because they want to save the community and save everybody. And so they were heroes. But we knew, and because again, it's the normal human response, and this is a classic, something called the Zoonin-Myers curve, we knew that after that heroic response, and we'd have this little honeymoon, that we were going to hit the valley of despair afterwards. And that's kind of where we are now, and that people are just exhausted and they're tired and they're cranky and they're frustrated and they want it to be done. And when they see a light at the end of the tunnel, they want it to be freedom, not a train. And so we're still in the process of navigating that pit of despair, I think, as a country, much less as a health system. But that's expected. And so we started talking about that and started thinking about how are we going to support our own caregivers, our doctors and our nurses and our cafeteria workers and our parents who have kids in school that they can't get childcare for, right? So we knew we had to start thinking about this, because if you go to the next slide, we knew that we were trying to get patients back into needed care. At the same time, our workers are tired and frustrated and exhausted. And it's really hard to be in the service industry. And if you think about healthcare, it is the ultimate service industry when your workforce is tired, exhausted, frustrated, and just wants to go home and curl up in a ball. And so we started putting a lot of support in for our workforce, everything from ensuring, paycheck protections in addition to what the government had, ensuring we had online childcare, and then a lot of emotional support. We started a program called No One Cares Alone, where we have peer-to-peer support from caregivers to caregivers. And we even have on-demand cognitive behavioral therapy, so counseling. So if somebody's feeling tired and frustrated, they can call up and get like a counselor on the phone on demand, which has been really helpful just to minimize the valley of despair that we know people are in right now. So next slide, please. That's kind of the reaction phase. In addition to working very closely with the government, we've had a huge number of phone calls with everybody from the CDC to Health and Human Services to the White House, really helping ensure that we can move the response forward, not only on a state-by-state basis, but across the country. Trying really hard, by the way, we're big believers in the World Health Organization, that if COVID is uncontrolled anywhere on the planet, it's not good for the country. And so we really have to think globally when it comes to something like a pandemic. And so we've been working hard to make sure that what we're doing within Providence, everything from rapid learning with our huddles, with our grand rounds, we're sharing with other organizations, with the CDC and with the Globe. And by the way, we've been a receiver of many good things as well. Early on, we had lots of conversations with doctors in China, doctors in Italy, to make sure that we could advance our capacity to care for people much faster. Next slide, please. The other thing that we've had is being very consistent. So, COVID initially, particularly, and even now, I'd say, people just feel like there's, I don't know the best analogy, maybe like you're standing in the middle of a field and people are throwing stones at you. You just never know where the next rock is going to come from. And it just feels like you're at the mercy and you're victimized by this invisible germ, right? And we said, we don't want people to feel like victims. We want people to feel a sense of control, a sense of calm, a sense of knowing what's coming. So we'll absorb those rocks. And because health is always like that, you never know the next bad thing is coming. So healthcare should be able to deal with that. But we at least want to have our people supported by some regular things. And so we made sure that we had very open communication at all of our facilities on a daily basis, hearing what are your concerns, what's going on, make sure we know about it. We synthesized all of that information up at the system level. Oh, you don't have masks. Oh, you don't have somebody to support your ICU. And so we heard them, and then we communicated out. So we did that every morning, and then communicated out that afternoon with, okay, this is how we're getting more masks. This is who we're going to redeploy to support your ICU, so that there was never any long lags, and people knew that at 7:30 we'd have the huddle, and 11 a.m. we'd have the emergency operations center, and we'd have the broad communication out at 4:30 in the afternoon, so that there was some kind of predictability in an otherwise feeling like chaotic environment. And it really did help kind of take the temperature down on across the organization and across our markets, to feel like, okay, we got this. We're not just at the mercy of the next incoming missile. Next slide. So that was all in this reactive, and we'll just call it wave one, even though I don't really think we're in wave two right now. We just have never gotten control of wave one, but in that initial phase, in the react phase. But then we started saying, okay, now let's start thinking a little bit ahead. Let's not only be reactive, let's actually start responding and try getting ahead of what we can expect to be coming. So if you go to the next slide, we said that all right, patients are going to get frustrated if they hear different things from different voices, like we all are right now. I think living in different states, it's kind of crazy making, right? Because different governors say different things and different. So how can we, at least as a health care enterprise, as a community, come out with one voice to say, this is what we believe the science supports as the best way to get started again, getting care in addition to COVID, because it turns out that about 90% of the patients in our hospitals don't have COVID. And so how do we make sure that they're safe? What can we do? So we built coalitions in all of our states so that we could be very consistent and coherent with messages, making sure that patients know what to expect and what to do and how to do it. And that was incredibly helpful. Again, just kind of taking some of the anxiety out of the community so that we could be clear and coherent. Next slide, please. The other thing that we did is we started doing a lot more public service campaigns. And those public service campaigns, we used our own people to make them be very authentic. And so we started initially it was around, this isn't going anywhere if you go everywhere, and about just asking people to stay home. And that was at the peak of the pandemic. We also started something called the 100 Million Mask Campaign, because we saw the shortage coming in PPE, and that took off immediately. It was like pretty amazing. So we got lots and lots of community support, but it really was kind of helping us be ready for what's next and make sure that we never ran out of our PPE. And that was really out of desperation, because we didn't know what else to do to protect our people. So it was incredibly helpful being able to work with our communities to support caregivers that were trying to support them. Next slide. As part of the realizing that healthcare does not exist in a vacuum, we exist as part of the communities that we serve. We also realized that masks had gotten very political. They are very effective. They cut dramatically down, probably upwards of 80%, the chance of any individual person getting COVID. So wearing a mask would actually get us out of this mess that we're in. But it's gotten politicized to wear a mask. And so we said, okay, take it out of the political environment. How do we just make it cool to wear a mask? So we started working with one of our ad agencies to say, let's start a public service campaign to make it cool to wear a mask. And so, and then we went to the Catholic Health Association and the American Hospital Association and said, would you work with us on a campaign? And so they started campaigns. So now we have multiple campaigns ongoing to wear a mask. And that really is about saying, how do you change the dynamic? Like, let's just not make this it's about politics. Let's just make this about caring for your neighbor. And so with CHA, we developed a Love Your Neighbor campaign, Love Thy Neighbor. With the American Hospital Association, they're joining us in a Work Your Mask campaign. And it really is about saying, how do we just depoliticize this? Let's make this a kitchen table issue, not a political issue, so that we can actually move on to the next issue, the problem that we need to solve, instead of dealing with a pandemic. Next slide. We also realized we had to, the biggest thing that was going to get us out of the morass is finding treatments in the short run and a vaccine in the long run. So we started very quickly and almost out of the gate doing research that we had to understand how the virus behaves, understand its weaknesses, and then exploit those weaknesses. So if you go to the next slide, we very rapidly, and in fact, the first patient that we treated, we used the drug that you've probably heard of at this point, remdesivir, and had a great reaction with remdesivir with patient one. We then worked with the company to set up multiple trials with remdesivir and have the largest number of, in fact, we have about half the number of people who've gotten remdesivir in any of the trials across the country, across our footprint, because we were able to open up clinical trials and get it for our patients very, very quickly. In our own internal data, it cuts mortality by about half, about 45%. And we've seen a dramatic drop in mortality. The first month, about 25% of patients who got admitted to the hospital died, which was horrific. And by last month, it was down to 8%. And so we've had huge improvements in how we're identifying and treating and minimizing the risk to people who've had COVID. You have to be pretty sick to get into the hospital. So having 8% is a lot, but it's a whole lot better than it was. So we're happy. We're also doing research on what it's like for our people who've been caring for COVID, because with all of the disastrous PPE initial work that we had, we were just, we were trying everything we could to keep our people safe, but we don't know if we did or not. And so now we're going back and checking our own caregivers for antibodies. By the way, we call all employees caregivers. So because they work in an organization whose job it is to provide care, so caregivers. So we are now doing a study to see whether or not the percent of healthcare workers who have exposure to coronavirus is higher than the percent of people who live in that community, so that we can understand whether or not, I mean, the only way we can continuously get better is if we continuously learn. And so the goal is to learn whether or not what we've been doing is keeping our people safe. And I am, knock on wood, it is, but I don't know that for a fact. And so we're just trying to be open and transparent with information as we build it, so that we can learn faster, so that we can get in front of this faster. Next slide, please. We also know that the future is digital. So we have a significant investment in saying, as we move forward, we want to ensure that the tools we're creating for patients and for communities and for companies that are trying to get started again, for the NBA, as they're trying to get games going, we want to be able to have a way, if somebody does have the antibody, if somebody has evidence that they are at least temporarily immune to coronavirus, they should be able to have that available. So one of our portfolio companies that we own is called Lumedic, and I am on the board of Lumedic. But the reason I'm on the board is because I believe in them. They're a blockchain-enabled company, and so we've turned what they were doing, which was working on revenue cycle problems in healthcare, to saying, how do you have a digital version of a blockchain-enabled, so highly secure proof that you're immune to coronavirus. And oh, by the way, you can do that to show that you've had your tetanus shot and your flu shot, and you're immune to measles and other kinds of things as well, which for healthcare jobs are really important to know that you're immune to measles and hepatitis C, for example, hepatitis B. So having a digital credential is a really good tool beyond the COVID environment, but right now we're able to actually use this tool to demonstrate, to give results back to people easily and seamlessly in a very confidential way, and then they can carry around with them their results. But as we're thinking ahead, it's how do we actually use this moment to create the tools that we think will be helpful in the future. Next slide, please. In addition, we're doing a huge amount of research on everything from population health, like saying, how do we understand the long-term outcomes that are affected by coronavirus. And so, think loss of smell, weakness that some people have. And so we have something right now we're doing called My COVID Diary to learn what are the long-term implications of coronavirus. And hopefully there'll be none, but there might be some. And so if there are some, the only way we can figure that out is if we understand. So now we have citizen scientists, basically people who've had COVID or are now negative, that are recording their symptoms, and so that we can all learn from what's happening with the symptoms long-term. In addition to numerous other studies that we have going on. We have about 2,000 trials right now happening across Providence to really understand the science as we move forward. Next slide, please. So the other thing that we're doing is, in addition to COVID, as you all know, it is not the only crisis at the moment, is we're working on the other two as well, because we have to, because our own caregivers and the patients that we serve live in the communities that are dealing not only with the pandemic, but the fact now that they can't afford care. And so we can't afford anything, housing and care. So we're working with our community benefit partners. We're a not-for-profit health organization. And so we have deep ties with the community, working on housing for people that are no longer able to afford their rent. We are on the West Coast where we have a huge homeless population. And so we work with the cities to purchase hotels and make sure that people have a place that if they were diagnosed with COVID and need to sequester themselves, have a place to go. And we think in the long run, by the way, that those rapidly purchased hotels could be repurposed to long-term housing. In the housing first movement, there's a lot of evidence that giving somebody a house, allowing them to have a place to live, actually dramatically lowers cost to society from care, because housing is such a great way to keep people healthy and keep them off the streets and keep them out of trouble. And the next one is on social, that we're doing a lot of work in our communities to ensure that we don't have care deserts for patients, that if there are underserved areas, that we are putting testing centers there and on-demand everything from pop-up tents with walk-in clinics, as well as offering up our emergency care services through digital tools on demand, so that we can actually distribute care to where the need is in a way that is much more equitable than it has been in the past. Next slide. And last but not least, and it's very quick, and I promise that I will be done in a moment because I'm just dumping a lot of information on you, and so I've either burned you out or you'll have lots of questions. I'm not sure which one. The last phase, and the phase that we hope we're entering now, is recover and renew. How do we actually use this moment, the crises that COVID stimulated from the pandemic in the economy and with social justice, and how do we use that to actually start thinking about how to reconfigure the healthcare system so that it does deliver what people want and need at a price they can afford in a way that there's a sustainable business model as we move forward. So if you go to the next slide, we started, and this was actually in, I want to say, April. So while we were in the peak of the first moment of the pandemic, we said, we have to think ahead. We have to plan ahead. How are we going to, in the next 6 months, be ready for what's next? And we said there's 5 big things we have to do to make sure that we're ready for what's next. One is we have to make sure people know that healthcare is safe, because during the peak of the pandemic, people with heart attacks stopped coming to the hospital, which meant they stayed home and they died. Right? I mean, this is bad. It's a bad thing. You don't want that to happen. So we had to figure out that people knew that it was going to be safe to come in and get care. We don't want people to medically distance. So we knew that we were going to have to really focus on safety as what we did. We knew that we wanted to make sure virtual care stayed. In 2019, our organization did 70,000 virtual visits. In April of 2020, each week we were doing 70,000 virtual visits. We went from 70,000 in a year to 70,000 in a week, right? The capacity to do virtual visits existed, the potential existed. Nobody was doing them. They just hadn't done that shift. And we wanted to make sure that that shift stayed available to patients who needed it, because it's a heck of a lot easier to like do this for half an hour or, 20 minutes, whatever it takes, than it is to take a shower, hop in a car, drive across town, in traffic, wait in the doctor's office, get seen, right? So for patients, it's much more conducive to simpler access to care, to do virtual care. We wanted to lock that in. Reciprocity. Another thing, the reason we were able to take nurses from one state and move them to another is because during the crisis, rather than the state of Washington and the state of California saying you had to individually get licenses in each state, all of a sudden across the nation, we said, okay, if you got one, it's good everywhere, right? So that reciprocity all of a sudden opened up worlds of possibility for us to meet demand wherever we needed. We wanted to keep that. Value-based care. We also wanted to make sure that people didn't have to think about paying for widgets, which is the stupid way we pay for healthcare today. It's fee-for-service medicine. Sorry, there's geese right outside my door. That you had to pay for individual elements of healthcare rather than, and I always liken it, it's like if you had to buy a TV, one dial and the remote and the screen and the case and the plug all individually. And that's the way we sell healthcare, right? Why don't we just do this upfront payments, what's going to cost, and get everything for one price? So that's what value-based care is. And then the last one, which I can't see, strategic mix. It's how do we make sure that we're really thinking about what's offered where and how do we do that? That should we be doing heart bypass surgery everywhere at every hospital? Because it turns out if you do it at less hospitals with more cases of heart surgery all in one place, you actually have better patient outcomes. Patients get better care in high volume centers. So we started thinking about, okay, how do we rapidly do this? So that was the short-term vision, the 1-year vision. But then next slide, please. We also said, actually go to the next slide. Yeah, that's okay. I'll go back to this one. Okay. We also said we need to know what's going to happen with COVID because what's going to happen with COVID is going to make a difference on how fast we can go. Because as long as it's cropped up, we can't do much else. And so we developed a model where we figured out we had to figure out how well COVID was controlled in a community. What is the testing percentage positive? What's the healthcare capacity? Do we have people who can do contact tracing, and do we have ways to isolate patients? And we said that in our communities, we have to understand what that is to know what's coming. And it would allow us to kind of future cast. So that was kind of conceptually what we came up with. And next slide, what we did is we then put our crackerjack data analysts on it, and they were able to develop this kind of future casting. Next slide, please, Kathy. The future casting view, being able to predict what's coming. And it's been super helpful because now we can see right about 2 weeks into the future. Nope, one slide back. 2 weeks into the future. There we go. By 4 simple metrics. And this happens to be across our entire system, but we have it for each of our markets. And so Alaska looks different than LA, looks different than Orange County, looks different than Lubbock. But what we're able to do is we look at something called syndromic surveillance. How many people are coming into the doctor's office with fever, cough, shortness of breath? And you can see there back in after 4th of July, that went up, right? And that went up. And what happens when that went up at around 4th of July, you can start seeing that all of a sudden that not only people are having symptoms, but their percent of tests that are positive go up. And then you can start seeing that about a week after that percent of tests being positive go up, hospitalizations go up and ICU stays go up. And so by looking at who's coming into the doctor's office with symptoms, what is the percent positivity in our tests, we can get like a week or 2 head start on whether or not our census is going to go up, and we can be ready for it. So that kind of future casting has really helped us a lot be ready for the peaks and valleys that we're seeing. Next slide, please. And now we're actually turning that into another product, like our Lumedic product, that the digital credential is one. Detection Map is a product that we're putting out there and being able to give to communities to say, hey, this is what to expect, and the future casting you can look at so that you can understand what the syndromic surveillance information and test positivity and all the predictive tools we have is showing in your local market so that you can be ready as well. Next slide. The other thing we did is we said, okay, that's in the 6-month vision. We've also got to do a longer term vision. We have to understand how we're going to deliver on what our promise is to our patients at Providence is know me, care for me, ease my way. How are we going to do that, and how can we be ready for that? And so I put some links in, and you guys look at these slides if you want to look at each video is like 3 minutes long, but it kind of shows you how we're thinking of what we think the future is going to be. How are we going to get ready for that future? How are we going to make sure that we create the future we want, not the future that we stumble into? And so we're using those videos to help us actually, and nobody can predict the future, but we can create the future that we want more effectively if we envision where it is we're going. So next slide, please. What we've been doing then is using what we've learned in our reacting phase and our responding phase and our renewing phase to say, there's a few lessons we've learned. We're just going to keep these in our back pocket, and we're going to keep moving forward. We're going to keep envisioning this future. We're going to keep reacting and responding to the things that come in our path, but we're not going to stop there. We're going to actually use this to make sure that we're ready for what's next and that we create the future we want to live in. And so we're hoping for the best, planning for the worst. We're learning from the past. We're making sure people understand that the healthcare infrastructure is fragile. It needs investment. The environment's chaotic, but we don't have to be. And that one voice works better than a cacophony of 1,000 voices. So if you go to the next slide, I do really like our vision. So the promise that we'll give patients is to know me, care for me, and ease my way. But our reason for being, the reason we get up out of bed each morning, no matter how many rocks people are throwing at us or germs people are throwing at us, is that we really do want to leverage health to create a better world. And that's what we're trying to do. And very last slide. And I'm actually going to read the words on this slide, because in that vision of health for a better world, we know, and there's great articles out there now. There's a good one on just from National Geographic from mid-July, I think, on how pandemics have changed the world. And so that's what we're thinking. That is with 160,000 Americans dead, it's hard to call it a silver lining. But you don't want those 160,000 human beings, those moms and dads and brothers and sisters and sons and daughters, to have died in vain. So what is it that we can do to honor what horrible things have happened? Is that we can use this pandemic to break with the past and imagine the future in a different way. And that we need to use this pandemic, as the quote says, as a portal and the gateway between what we have today and what the world is that we want to see. And we can choose to walk through that portal, and we can drag through our prejudices and hatred and avarice and dead ideas and dead rivers, or we can walk through and lightly and think about how to make something better, leave all that baggage behind, make something better in the future, and be willing to fight for it. But we can only do that if we have the courage to come out on the other side with a different model than the one we went in with. And so that's what we're trying to do today. So I talked you through a lot of how we reacted, how we respond, and what I hope for how we renew the health and healthcare system. And so I'm gonna shut up now and let you guys ask all kinds of questions that you want.
That was awesome. That was awesome, Dr. Compton-Phillips. Really, really amazing. And I'm obviously getting feedback from others saying the same thing. You're honestly, you've got a really dynamite personality, and it really comes out in your presentation, and just, it's just really nice to have you. Really is nice to have you. I'm going to ask the first question. I never do, but I'm going to this time. And I want to throw a hardball at you right away. Okay. And I want to ask you, if you had children that went to school, and maybe you do, would you send them to school? Dr. Sanjay Gupta's already tuned in on this one yesterday, but I want to know what you think.
Yeah, so my kids are in college, and I did send them back to college, but they're rational human beings and they're wearing their masks compulsively. They're washing their hands, and so it's a little bit different issue. They're also doing really rational things like, all those I don't know, biology 101 classes where you have 400 people in one room. Those are all virtual. And for the upper level classes, they're junior and a senior. They are using those big empty 400-person classrooms to do these upper section courses where there's 20 people all spread out, right? So that's rational. If I lived in an area where the virus were under control and the school were, particularly for kids over 10, had a way to distance the desks and minimize the risk, because they actually had hand washing stations and hand sanitizer and were requiring to wear masks, I probably would send them to school if the virus were under control in that community. There's a lot to be said for school. There is children being able to not just learn, but interact socially and get screened for hunger and child abuse, right? So there's good things that come from school. If I were in a community where the virus was raging out of control, no way. So
Okay. We're faced with that one right now. Trust me when I say it's a real challenge, because of course we know it's a positive thing for our children to go and so forth. But at the same time, man, you can't help honestly but feel a little bit like you're being like kind of guinea pigs. And in a sense, and the kids are going to go, and what's going to happen that first few weeks? I mean, that's kind of the feeling you kind of get. And of course they put you in a bind where you if you make a decision now, you got to stick with whatever that decision is for 9 weeks or whatever. And 9 weeks, we're looking at a very different world in 9 weeks, one way or the other, probably.
Right.
So,
And yeah, no, you're 100% on. The other thing is like this, and I'm sorry, it feels to me like a Copernicus moment, right? Or a Galileo moment that the somehow, like, saying the truth that masks work is politically fraught, and like the Inquisition is going to come down on you and clamp down on this truth telling, and so there's this like anti-science movement. It's like anti-vaccinations. Vaccines work, by the way, folks. On the phone, if you guys need evidence, let me know. I'm happy to send it to you. Masks work, and so asking people to wear a mask isn't all that hard. As a doc, I can tell you, I can wear one for 8 hours or 12 hours in the hospital all day long. I don't get carbon dioxide poisoning. I can breathe perfectly fine. I can be on my feet running around all day long, and it works, right? Masks work. So if we did that, it takes something called the R naught, or the effective R naught, the transmission rate for the virus, down below 1. That's how you kill the spread. And so going back to school with masks on, even for kids who aren't particularly perfect about washing their hands, would make it so much safer. So yes, if under control and masks required, I'd be perfectly comfortable with schools. If it's not under control, it needs to get under control before sending kids back to school.
Thank you. We do have a number of questions that are lined up, but I do want to quickly give my good friend, Dr. Barry, an opportunity to chime in, because I'm sure he'd like to say hello to you, and maybe he's got a question he'd like to ask you.
Well, thank you, Richard. Thank you, Dr. Compton-Phillips. That was absolutely wonderful. I agree with you. I think that the silver lining with COVID, this horrific virus, is that it's an opportunity to reinvent healthcare and to make it more humane and more inclusive, to make it more excellent. I'm a student of Kaiser Permanente. I've studied Kaiser for a long time. And I just wonder what influence your 20 years at Kaiser has had on your leadership at Providence.
I would say very strong. I was there literally from I joined in 1993 and I left in 2015. So it was 22 years, and it's hard to have, I joined as a baby doc, right, as a straight out of residency. And so my entire professional practice was in a group model capitated system. And I believe that is the way to provide care that is rational, high quality, and effective. It's also very much the permanente. So as you know from the studying KP, that there is 3 legs to that stool of care provision. There's the Kaiser Foundation Health Plan, so the payment side. There's the hospitals, so the capital intensive place you have to go if you're in a car accident, you want one of those around, right? So there's the hospital side, but that's a capital intensive thing. And then there's the physicians. And the 3 legs of that stool work together effectively. Other organizations don't have all 3 of those working in sync. And I think it's why KP is able to work so effectively. That said, KP, when I joined in 93, covered 3% of the American population. When I left in 2015, KP covered 3% of the American population. And so if it was the perfect answer for the American population, in my mind, the community would have voted and would have grown beyond 3%. And so kind of coming into Providence, kind of my thinking was, and the reason why the CEO was able to recruit me there was to say, can we take what we learned at KP, what works really well about that balanced capitated model, and be able to apply those lessons into the rest of American healthcare? How do we figure out that for the 97% of people who don't have Kaiser? Yeah. And so that's exactly what we've been trying to do. And one of the things that I personally believe, and we're on a mission to do, and one of my colleagues on the phone has been working with me to really get a dialogue going in the same way that we were able to start a 100 million mask campaign and our campaign on making it cool to wear a mask. Can we start a campaign saying that it's not Medicare for all, which I am not a fan of, not Medicare for all, but can we do primary care for all? And primary care for all in a capitated way. So you know that every month, X dollars, $100 per person per month, and it's all you can eat primary care. And I think if we had that kind of thing as a across the country, a right, not a privilege, that we would dramatically lower the inequities in care that have driven the honestly just heart-wrenching difference in outcomes between communities of color and everybody else. So I think thinking of health and healthcare as infrastructure to invest in the economy in the same way we do roads and bridges would be a great benefit to the country, and particularly the low cost. It's less than 10% of the cost of healthcare to pay for primary care, and it's a great equalizer. Oh my God.
Thank you. Excellent. All right. So actually, I should ask you just real quick. Do we have a 5:30 hard stop?
I'm good. I could go a few minutes longer if you guys wanted to, but
Okay. Okay, I just want to make sure I'm careful with your time. So Aaliyah, she is one of our MS Business students, she says, first of all, thank you for your time, Dr. Compton-Phillips. With many students returning to school and campus, do you anticipate seeing another spike late August? Are healthcare systems expecting and preparing for this?
Healthcare systems are definitely expecting and preparing for it. And, one of the big things is that people getting back together in larger crowds mean that there's more risk of transmission. And so if we were in Europe, if we were in New Zealand, it might not happen because the community burden of disease is so dramatically lower. The problem we have right now is we have, and again, this is like a peanut butter answer. If you look at the entire country, our community burden of disease is so much higher than we thought it would be at this point. And because of that, some people coming back to school and going to frat parties and doing what people do because they can't help themselves, will get back together again and we'll have cases of transmission. The goal is a couple-fold. One is if we all wear a mask, it won't happen as much, but it's really hard to do if you're at a frat party, which I get. straw hole or something. I don't know. But the other thing is that if we have treatments so that if people do get it, can we have, like right now, there's a lot of not just drugs like remdesivir that you use if you're sick enough to be in the hospital, but can we do things like antibody infusions? Right now, they're working on creating monoclonal antibodies that you could get. So instead of having a vaccine where you make them yourself, which is not going to be no matter what you hear on the news, it'll probably be available in early 2021 if things continue to go as well as they're going right now. But there are antibody infusions could actually maybe tide us over. And the question is, can we afford that to do that for everybody? Probably not, but at least if there are outbreaks, I'm hoping by fall we'll be able to have some better treatments for them if they happen. The other thing we're worried about is what we are lovingly calling fluvid, that if we get flu and COVID at the same time, we're not sure how that's going to react on the human body. And so everybody on this call, all your friends, all your neighbors, all your parents, tell them to go get flu shots. We don't want that to happen. It just sounds like a bad mix. And so we're trying really hard to keep from finding out, because I can tell you that it's hard enough for the body to fight off one of these germs. Fighting off two at the same time it's not going to be pretty.
Thank you. I actually like Ashley Gibson. Ashley, I like your question. What was the most surprising discovery, observation you experienced during this pandemic?
The most surprising observation. Trying to think of the best politically correct answer I can make. Okay, so I'm just going to be honest. I won't be politically correct. So the one I was most surprised by is that, and we have known for a while that the CDC has a pandemic playbook that then moved over to the National Security Council. And so the most surprising thing that I saw was the lack of following the science and the evidence and the evidence-based practices from national leadership. And so I think was the most surprising thing. And so we actually had to band together, and I feel like it's been a bootstrapped response from the medical community and from community partners, trying to make sure we made things work. So that's kind of the big picture, most surprising thing. And unfortunately, it's not a good one. But the positive, most surprising thing was that bootstrapped response has just been heartwarming. The fact that I can call up any one of my colleagues, the competitors. I mean, health systems fight tooth and nail for our 3% margins that we survive on. And so we need customers, right? But it's like, we're not competing on this. We're not competing on this. And oh, by the way, I'm not competing with China, and I'm not competing with Italy, and I'm not competing with France. And so let's get everybody together and we're all going to talk about it. I was on one call with how do you take care of pregnant patients with COVID. And none of us had enough patients that were pregnant with COVID to figure out what to do. And so we ended up talking with docs in Brazil and in, I think it was Lithuania. And there was literally like 4,000 physicians on the phone sharing what they'd learned to turn all of our anecdotes into enough information that we could use to work on. So I think that kind of I don't like the fact that we didn't have a coordinated response, but I do like the fact that the medical community and pharma and state governments all came together to say, this is what we know, and let's use that to keep going.
That's great. Maybe a couple more questions. Brian Waters, one of our full-time MBAs. Brian, how has Providence had to adapt their facilities for the surge in patients? Has there been a challenge in adequate manpower, womanpower, and PPE for alternate care facilities like retrofitted hotels and arenas?
Yeah, absolutely. And so what we did, we never had to actually use any retrofitted hotels and arenas for patient care. We had to use them for isolation, which is a little bit different, like, homeless people who didn't have a place to stay but had COVID, so that we would put them in these individual hotel rooms. But in our own facilities, we had enough space, and we were like ready to convert over offices, right, and put hospital beds in them. And but we had some really great MacGyver folks going on that cut holes in walls and put in these, you know, basically like swamp coolers that could turn into, with HEPA filters on them, so that we could turn regular rooms into negative pressure rooms, because we knew that venting the airflow, getting good circulation, turning over the airflow several times an hour was a way to minimize the risk for not only patients and their loved ones and but staff as well. So we did that very quickly. So we have like all these random, you know, rooms with big old machines where normally you'd have visitors' beds, you know, so they could stay with loved ones. So that was big. The other thing we did, and it was really bad initially, but now it's a lot better, was we shut down anybody who didn't have to be there. And I don't know if anybody's been in the hospital, like you don't really want to be in the hospital. And if you do want to be in the hospital, if you do have to be in the hospital, you want someone you know and love to be there advocating for you and holding your hand and keeping you company, because it's a lonely place. And we made that not happen. And we changed the facilities to be like Fort Knox. And, you know, it's a little prison-esque that you have to be able to demonstrate why you're coming in, and you're going to get your temperature checked and put your mask on. And so it's a much less inviting place during the pandemic. We've now gotten to the place that we let all visitors have one loved one in with them. And in fact, if it's a child, you can have two. That's a big bonus prize. But it's been, you know, we've made it work, but we've made it work by hook and by crook. And it's less inviting than we'd like it to be, because you want a hospital to be a healing environment, not a prison.
Great. Okay, one last question. Allison's one of our MS business students. Thank you for speaking with us, Dr. Compton-Phillips. This is a great question, because we hear so much on hydroxychloroquine, and we all know where that's led us. What is the mechanism of action of remdesivir, which you've already talked a little bit about, on COVID, and how does it work?
It stops viral replication. And so it interferes with the ability for the DNA chain to replicate itself. And so that it just basically stops the production of the virus. And so that's how we think it works. And it's why it works when the virus is getting worse, because that typically is because the viral load is increasing. As opposed to other drugs like dexamethasone, which tamps down the body's overreaction to the virus. So you can still have the copies of the virus around, but your body doesn't react as strongly, which, by the way, is you guys might have heard of the concept of cytokine storm. Cytokine storm is the body's overreaction. So in fact, the two things work really well together. If you block the ability of the virus to grow more copies of itself, and you block the body's reaction, you can really minimize the damage that COVID does long-term, particularly to the person who got it.
If you don't mind, only because this is specific to Providence, I think you might want to address this one. This one last one. Antone asks, when we get a vaccine, it will only be effective if many people take it, as you well know. Has Providence considered a rollout strategy model? Will it be targeting particular at-risk groups, or by age, or by location?
So we actually have an ethics group right now looking at if we get to be the deciders, and I don't know if we will or not, how we're going to actually do this. And it will depend a lot on the nature of the vaccine. And by the way, I don't think it's going to be one vaccine that gets approved. My guess is out of the 170-ish now in development, you know, we'll probably have in short order 2 or 3 or 4. Also, if it's just one vaccine, it's hard to scale up production enough to be able to get that to sufficient people. But so kind of the thinking right now is at-risk people and healthcare workers. But that depends. At-risk people may or may not make an immune response to the germ, to the virus itself, vaccine itself, sorry. So it might need to be people that work with or are around or support at-risk people in addition to healthcare workers. And so that's the current thinking, but we'll have to see the features of the vaccines that get approved, who they work in, and how many of them we have. And then we start going down, what's the priority order so that we can protect the most people in the fastest way.
Excellent. Well, look, it's been a real pleasure, a real nice hour and 5 minutes with you. Thank you so much. Really, we really appreciate your time this evening. And I'm looking forward to staying in touch with you, obviously. And, if we can ever help, you never know in some way, always happy to help you. And I'm, consider me at your beck and call. So really appreciate it, Dr. Compton-Phillips. Thank you very much.
Well, thank you so much for having me. I really appreciate it. And thank you all. Good luck during the school year starting.
Thank you. It would have been nice to have had some politicians on this listening to you as well tonight.
Yeah.
Thank you so much.
Take care now. Bye-bye.
Bye, y'all. Thank you.